Regarding the aim of surgery in area deformity is maximum accepted correction, balanced spine, and minimal or no complications. Screw density is defined as the number of spinal anchors, whatever the type, whether screws, hooks, or wires, per level fused. The bilateral placement of pedicle screws at every level results in the maximum density, that is 2. The equation, this is the equation of the density, the number of screws or anchors divided by the number of fused levels. In the high density, it's more than 1.8 implants per fused levels, low density 1.4, and the intermediate density from 1.4 to 1.8. As this is an example, if we count the screws, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, for 10 levels. And so if we divided the 11 by 10 by 11, and it will be 1.2, this is low density. Intermediate density less than 1.8, and the high density will be 2. The rationale for high density is to improve the biomechanical stability and the correction potentials, and provide better control over curve correction in complex curves. The advantages, of course, enhanced correction, especially for severe deformity, and the better sagittal and the coronal alignment, but they have higher risk of complication than the low density. As pedicle screw misplacement is about 3 to 5%, and increased cost and operative time. Regarding the low density, they have the advantage of minimizing invasiveness while achieving essential correction, and the target fixation is mainly for the key vertebrae, the apex and the periapical area. The advantage, of course, low cost, short operation time, and reduced risk of complications, but some drawbacks is potentially less control over correction, and may not be ideal for more complex or large curves. This is a good study regarding the what's the cause of loss of correction. Loss of correction definition is if you have correction, loss of correction more than 10 degrees or 25% of the correction. The apical zone of the convex side and the periapical zone of the convex side is very important to pay attention for the implants. And of course, increasing rod rigidity tended to lower the likelihood of correction loss in both convex and concave sides. Here we can see here, this is the apical and this is the periapical above and below. This is the most important area to put in consideration while putting your implants. And here also, this is the higher incidence for loss of correction was at the apical and above and below the apex. Low density construct, the indication, of course, I used it for adolescent idiopathic scoliosis only. I use it for Linky 1A, C, 1A and C, and Linky 3. Curve stiffness is controversial. You can use it for the some rigid curves. And for cup angles less than 70 degrees with the sagittal profile hyperkyphosis, not hypokyphosis. This is a good start regarding the optimal surgical care, and they found that curves within 40 to 70 degree, whether implant you can use. 73% of surgeons agree for this. Concept from 70 to 90 degree, only 33% agree for low density, but the most of surgeons prefer the high density. And finally, the Cobb angle of 70 to 9 optimum implant density is based on several factors like bone density, curve rigidity, sagittal profile. Finally, regarding this study, they found that implant density more than 70% and less than 90% provided a correction similar to that obtained with implant density more than 90%. However, mean coronal curve correction was inferior for construct with an implant density less than 70% when compared with constructs with implant density more than 90%. And also this study concluded that rods with high stiffness along with high screw density on the concave side could provide better outcome with respect to sagittal restoration. The advantages, of course, the operative time, the cost, and the complication. This is a case, 17-year-old girl, with Linke 3, 65 and 51 degrees. And here is the post-operative. The density was 1.3. It's a low density with adequate accepted correction. And this is the lateral view. This is another case, 13-year-old female, Linke 3, 65 and 40 degrees respectively. Density was 1.2. This is the post-operative. I have mild truncal shift, but I'm following this patient up till now. He is compensated up till now. This is a 14-year-old female, Linke 1C, 75 and 45 degrees. Density was 1.3, and this is the post-operative. This is a case of a 15-year-old female, Linke 5, 70 and 34 degrees with density 1.6. This is an intermediate density. In conclusion, both low density and the high density screw constructs show comparable and satisfactory radiographic and the quality of life for AIS patients. High density constructs had increased cost, operative time, and blood loss. Could we improve the quality, safety, and the value of otherwise currently widely successful pedicle screw fixation techniques by utilizing lower density constructs? This is a very important question. I have more studies to answer. Finally, it will continue to be responsibility of the surgeon to choose the most appropriate number of implants based on the best cost-benefit security ratio. I thank you very much for listening.